is medication.
Yeah, medication is commonly a problem. I mean, there's some medications that are vasodilators that cause headaches for the reason you were discussing, that vasodilation can cause some degree of headache pain. But I think what you're speaking more of is the medication overuse headache. So people can overuse over-the-counter medications, for one thing, because they have easy access to that. But you can also do this with prescription symptomatic medications, so the medications that you take at the time of the headache. So if you take those 3 or more days per week on average, so for several weeks in a row, you can actually cause a dull, daily chronic headache that does not respond to other medications. So you kind of try to treat a problem, but you create another problem.
Right, there is the rub. So with that, we'll get...
we do need to take a break.
Yeah.
Dr. Miles, please stay with us. And following these words from a Vera Medical Group, Dr. Holm and Dr. Miles will continue the discussion. If you have a question you'd like to address to Dr. Miles or Dr. Holm during this time, just give us a call at 692-1430. We'll be back right after these words.
Are you feeling down, sad, depressed? The Avera Medical Group Brookings wants to help you. There are many options to address your symptoms. Help is just a phone call away. Please talk with your provider today. You do not need to suffer alone. Call 697-9500 to set up an appointment. Remember, the providers at the Avera Medical Group Brookings are here to help.
Okay. Welcome back to Radio. We're happy to have you listening today. Dr. Carol Miles is with us, and she's from Sioux Falls, and she's here. She's a neurologist and here to talk to us about headaches. Welcome back, Dr. Miles.
Welcome back.
Thank you.
So, Carol, you tell us a little bit, before we dive back into the headache story, tell us a little bit about your headache clinic.
So our headache clinic is called the Headache Center. That opened in July of 2013, and that is a branch or an outreach of my primary office, which is Neurology Associate. But the Headache Center is open every day, 8 to 5, and we are always accepting new patients. We've gotten really busy, but we're always seeing new patients, and we see all headache types there. So we see migraines, we see these medication overuse headaches, we see cluster headaches. We're doing some research there on a new headache type called migraine. So we see patients, of course, with that type of headache there as well.
So let's talk about migraine first, and then I want to get in. Well, actually, we started about medication overuse first already. Let's get into that a little bit more.
Right.
What do people need to know about it? What medicines should they learn to avoid or to be wary of? And then, and what's the take-home on medication overuse headaches?
Well, the real take-home with that is that if you're needing to treat 3 or more headaches per week with a symptomatic medication, you really need to see your doctor, because you probably need to go on a preventive medication, so one that prevents the headaches rather than treating each one as they come. Well, you would actually still treat them as they come, but the preventive should cause those to be less frequent and less severe. But a medication overuse headache is a dull, daily, kind of a nondescript headache. And it just makes people feel worn out and bad. They can't concentrate. It actually disrupts their sleep. And it's really common with combination medications like Excedrin. So in Excedrin, it's Tylenol, aspirin, and caffeine. So the caffeine and the Tylenol are both rebounders. So you have 2 rebounders in that same medication. But you can do it with Tylenol alone. You can actually do it with like Aleve or ibuprofen, but it's a little harder to rebound from those. So you can actually even do it for prescription medications like Imitrex or Max Ultra, that whole category of medication, if you're using them too frequently. So if you find that you're using any medication 3 days per week or more for several weeks in a row, you need to see your doctor and ask about a preventive medication.
So let's take a person who has osteoarthritis and their rheumatologist has prescribed a non-steroidal anti-inflammatory for them on a regular basis. It's not a as-needed basis, and it's not a couple times a week. It's like every day, twice a day, and now they have a chronic headache. Well, what do you do in that scenario?
Those are really tricky. So I try to work with the rheumatologist to see what else we can use. But in the list of medications that cause medication overuse headaches, non-steroidal anti-inflammatories are actually lower. So you just don't want them you really don't want them using Tylenol or narcotics or caffeine or et cetera. And some people won't develop rebound headaches, which is synonymous with medication overuse headaches. But some people who take narcotics, for example, or nonsteroidal anti-inflammatories every day, if they're not prone to rebound headache, they may not develop it. But it's really, really tricky when they're taking a medication for some other reason and they develop rebound headaches, because then they get in this bad situation where they have to choose between the original pain, let's say the osteoarthritis pain, or
the
scalding headache. And that's a really tough one. I work with that a lot.
I mean, I have dealt with medication withdrawal problems all my life, and I've realized it's taken years of experience to realize that the biggest cause of constipation, for example, is stimulant laxatives, and the biggest problem for a lot of nasal stuffiness. The worst is the afronasal spray rebound, and so it goes on and on. Medication tachyphylaxis, that type of a problem is real, and if we can avoid medicine, sometimes that's the best. Do you think that herbals people have there's been a subtle understanding that medicines that are really effective are also sometimes problematic, and they've turned to supplements and herbal things as a result. What's your take home on those kinds of things?
Well, there are some herbal remedies, or some what people would consider more natural things that you can use for headache. For example, butterbur is proven to be effective in headache, and you can also use magnesium. People with migraines tend to have a lower magnesium level, and so patients will take magnesium. Riboflavin was in favor for a while, but that didn't really pan out very well. So some of these kind of come and go, but really right now, butterbur and the magnesium are the bigger ones that are herbal or natural, or medication that you don't need a prescription for.
Chondroitin and sulfate, that type of a thing. What do you think of glucosamine and chondroitin?
Those are good, but as far as I know, there hasn't been any study with that in migraine specifically, but certainly if you have some osteoarthritic pain and that's causing some neck pain and tension-type headache, that may be effective.
And then you would be able to avoid the other thing. The thing I learned from you that was absolutely blew me out of the saddle these last couple of years is the problem with Tylenol.
Right. Tylenol is just a really big rebounder, and the thing is, people just have full access to it. You can go to the store every day and buy a bottle of 100 Tylenol. And sometimes the other thing is people forget when they go to the doctor to list that on their list of medications. So we ask specifically about over-the-counters and any herbal remedies or natural remedies or anything that they're using, but people, I think, just forget to mention that to their doctor.
I've had such great problems with people taking nonsteroidals, a lot of upset stomachs, and so I have, through the years, turned to Tylenol more and more as time goes by because of the problems, the hypertension, the edema, and the bleeding, and so on, problems related to the nonsteroidals. But now I'm turning away from Tylenol too. I'm just saying, come on, just live with it. Don't turn to a pill. Get out and go for a walk, that type of a thing.
Tough choices.
And I think that raises a really important issue with migraine, is the importance of exercising at least 3 days a week. That's a proven effective treatment regimen.
I would say take a good exercise every day of some kind. You're talking my language, Carol. You're talking my language.
Carol, you made his day with that comment. He pushes exercise for good reason all the time. Right now, though, I have to push our next break. Please stay with us, Dr. Miles, and we'll be back right after these words.
Spring is finally here, as are the seasonal allergies. If you are one of the many in this area who suffer with allergies, it is probably time to see your primary care provider. There is help enjoy the outdoors.
Hi, welcome back to Prairie Doc Radio. We're happy to have you listening today. We have Dr. Carol Miles, a neurologist in Sioux Falls, who does quite a bit of work with people with headaches, joining us today. Welcome back, Dr. Miles.
Thank you.
And I do have a question myself. I do know of a few people who have chronic ongoing headaches. I mean, a year or two. They've been to neurologists. They've tried to get help. Do you have many patients like that you just cannot help?
Well, there are patients like that for sure. The patients that come to the headache center are those patients that have really been kind of filtered down to that chronic daily headache. Chronic daily headache is actually 4% of the population, which on first glance that doesn't look like that many people, but it ends up being a lot. In my practice, and if you were to follow me in my clinic, you would think that probably 90% of
people in the world
have chronic daily headaches.
Those are the ones that come to you, is that it?
Yeah.
Right.
Mine are almost all chronic daily headaches, right.
So, I mean, and the cause of the classic quote-unquote chronic daily headache, and I have a number of those, and of course, since I can't help them, and they keep asking me to help them, the doctors will say, gee, my chronic headache is this guy who has this chronic daily headache. I mean, he's the headache that I have every day.
Well, doctors feel bad when they can't help.
Well, that's really true.
That's it. You're there to help, and if you can't, you're at a loss.
That's right. But that's the question, Carol. What is, do you have data on that chronic daily headache? What the causes are, go ahead.
There are a lot of different causes. So what I do when I see the patient the first time is I take a really thorough headache history. I mean, I think people are so sick of filling out paperwork by the time that I walk in, because we take a very thorough history on paper. That way I can look at that. They've kind of thought of what I'm going to ask, and then we can just visit while we're there, and I can clarify things. But really what I'm doing with all of that visit is trying to sort out what headache type that patient has that are causing him or her to have daily headaches. And oftentimes it's more than one headache type. So a lot of times they're migraine, and maybe they're migraines that started out being episodic, but they feed on each other, so they gradually become more and more frequent. And then you start taking too many medications, and you add in there some medication overuse, and then you might have some tension type as well. And this migraine headache type is something that's not fixed by any other means other than neural lenses. That, like I said, that's an area of research that I'm working on. But really, I try to sort out those different headache types so that I can approach each one of those individually. Because at some point, you've got to really treat every single one of those, or it sabotages the efforts of any other headache type that you're treating.
If we're going to talk about migraine in a little bit, and I'd like to, but what I'd like to start with is differentiating between a migraine and a tension headache. How would you differentiate those two?
So a migraine tends to be, now they don't have to have all these criteria, but tend to be one-sided throbbing, nausea, vomiting, light-sensitive, sound-sensitive, worse with activity. So that's kind of the strictest criteria.
Say the last part. They're light sensitive, and what else? Sound and light sensitive.
Right. So they're the patients that are in severe pain, and they go to a dark, quiet room and they hold still. They don't pace around. They like to just hold still, and they get nauseous, and sometimes the headache might not be even as disabling as the nausea and vomiting. So any of those symptoms can be disabling in themselves. So that's like a classic migraine. Now, there's also some of those migraines, about 20% of migraine patients will also have an aura. And that tends to come before a headache, but it can come early. And it can be visual, like some sparkling lights or black spots or colored flashing lights. It can be numbness. In some patients, it can be dizziness, lethargy. It can be really different sorts of auras. So that's a migraine. A tension-type headache tends to be more of an all-over, mild to moderate headache. It doesn't tend to have nausea with it. And an interesting fact with that, the migraines, they said they're worse with activity. But a tension-type headache can actually improve with activity. So those are the ones where if you go for a nice brisk walk, it might go away. Whereas a migraine, if you try to go for a brisk walk, it's going to throb until you really get those endorphins going, and then it might help. But it's hard to get over the hump on that one.
The endorphins. So how do I get my endorphins working?
Well, really with exercise, I had a patient one time that was a collegiate runner, and she had really bad migraines, and she could get rid of an individual migraine attack, but it wouldn't go away until she got to the 7-mile point. So I don't know many people that can run that far with a throbbing headache before they finally get relief, but she was pretty tough.
That's an interesting story.
She had to really be tough.
It's 7 miles. Then the headache goes away.
Yeah.
So the neurochemical cause for a migraine is interesting. That means that there's not enough neurotransmitters, or there's too many, or what's...
It has to do, that's different for each of the neurotransmitters, but it has to do probably more with the fluctuation. So there's several different neurotransmitters, but we think serotonin and dopamine are probably the biggest ones, but epinephrine and norepinephrine. There's a new one that's really big, being talked about in research, called CGRP, which is calcitonin gene-reactive protein, and there's medications that are targeting just that right now, and those aren't out yet, but that's kind of the new wave. Like I said, there's just a lot of headache research, and I think we're going to get, hopefully pretty soon, another surge of some medications for migraine.
All right, and if it's indeed a serotonin problem or a norepinephrine problem, the medications that we are using for depression should be helpful, should they not?
They oftentimes are, not only because they assist with some degree of depression that can come from having the chronic pain, but because they stabilize those neurotransmitters. So a lot of times I'll see people that are also on, for example, Effexor. That's a really good one. That one's helpful for me, and it's helpful, I think, when psychiatry or the primary care providers have them on this for depression. But they're very similar. Depression and migraine go together a lot because they're from the same neurotransmitters, and so treating one oftentimes treats the other. Yeah.
Okay.
Dr. Miles?
So we're gonna talk drugs in a minute, but there's a good question that just came in.
Well, a caller just came in wondering, do you believe diet can affect migraines?
I believe that strongly, and I spend some time on the first appointment, especially with patients, discussing that. Now, there's a huge list of foods that can make headaches worse, but the problem is those foods don't cause headache in everyone, so they more have to identify their triggers. But the big thing with diet is first of all, eat on a regular schedule. Don't skip meals. Your brain is made to want to eat at 8, noon, and 6, or whatever your routine is. You can eat more than that, but don't eat fewer times than that. So the regular schedule is really critical. You want to watch foods with preservatives. So try to minimize your preservatives as best you can. So a big one for that would be hot dogs or any aged or cured meats. Lunch meat, you want to get it from the deli counter, not the stuff that's prepackaged that lasts for 3 weeks. So preservatives are bad. Caffeine, I think everybody knows about caffeine. A little caffeine is okay, but 2 cups of coffee is probably pushing your limit. NutraSweet is one that over the years I've noticed is almost as bad, if not worse, than caffeine. So try to avoid the aspartame or NutraSweet, which is like in diet sodas and things like that. But diet is really important.
I've heard that orange juice is a problem, that
right.
Almost all alcohol except for vodka can be a problem.
That's true.
Particularly red wine can be problematic. I know that for a fact that back when I was trying to learn how to drink scotch, that it was all a problem for me. Maybe it was because I was drinking too much of it, but certainly alcohol can be a problem. They say that vodka is not. I mean, what do
and actually the number one dietary trigger, I'm glad you brought that up, because the number one dietary trigger is alcohol. And it's interesting because most migraine patients do not drink. And when you do not drink alcohol, and when you ask them to list their triggers, they don't list it. But if I ask them specifically, they'll recall that the reason they don't drink is because they feel bad and they just have never learned to enjoy it. But vodka is the only one that's on the list of okay, and I have never seen why that is.
Maybe it's the potatoes. Don't they cook?
That's from an Irish person.
Oh, yeah. No, well, vodka is made from potatoes.
Yes, it is.
Right.
And of course,
maybe that's why.
That must be the Irish. That's how come the Irish can drink so well, or is that a?
Well, how well we don't know, but they do drink.
I was just joking.
Just joking.
We're going to take a break. Okay,
we'll be back in just a couple of minutes.
Do you find it difficult to reach 30 minutes of exercise?
Welcome back to Prairie Doc Radio. We just have a couple of minutes remaining. We've enjoyed having Carol Miles with us. She's a neurologist from Sioux Falls, and we've talked about headaches. We just talked about all the drinks you shouldn't have. If you really suffered from chronic headaches, what do you suggest people drink? They got to drink something.
Well, water is probably best. Milk is okay. Chocolate milk is on the list of not okay, and that's just because of the chocolate in it.
Sure.
But I haven't really found that to be a big problem amongst my patients. So water and anything without preservatives or additives is going to be the best.
I promised to talk about eye grains, but I want you to throw some information about medications that have been effective and that what people might be looking to. I'm afraid that most doctors just aren't that knowledgeable about this particular topic, a problem that affects 4% of the or more of the population. What would be the most important meds that people should know to take or not to take?
So, do you mean over the counter?
No, I mean what medicines, prescriptions can be helpful. Let's start with that.
So the prescription medications for symptomatic therapy, which is when you take it at the time of the headache, the really big category that's really effective is called the triptans. So that would be Imitrex, which is sumatriptan. Most people get that generic now. Maxalt, which is rizatriptan. Other ones would be Relpax, Emerge.
But you're not going to want to use those triptans very often because they're pretty tough on you.
Well, you can use them, 2 to 3 days per week, but they're pretty restricted by the insurance company, but also from a safety standpoint. So they're a little harder to rebound from, but they get to the root of the problem and get rid of the headache more quickly. So those are good ones. I really like Aleve or naproxen. That's really effective for headache therapy. I use some dihydroergotamine, which is a really old medication that's really effective for migraine as well. And then there's the preventive medications. So big ones would be beta blockers like Inderal or propranolol. I use a lot of verapamil. I like that one. Topamax or topiramate is a really common one. So those preventives are the ones that you take every day, whether you have a headache or not, to gradually make the headaches less frequent, less severe, and shorter.
Okay. And let's talk about eye grains for a very short minute. We've got like 2 minutes left.
Okay. So eye grains are a new headache type that we're researching here. We're about to take it to the next level because we're about to start a more rigorous trial. But that's a headache type that feels very much like medication overuse headaches. It's more of a dull headache. But it's worsened by reading or working on the computer, and patients that have this tend to have dry eyes, and they don't like bright light. And that's not just when they have a bad headache, but all the time. They just are people that put their sunglasses on right away. And they tend to have a stiff neck, too. So there's a test that we do. It's called a sight sync. We do that in my office. That's a free screening, actually. And the way that we treat that, interestingly enough, is with lenses. So they're called neural lenses. And it's really to make your two eyes work in sync with each other, so that it doesn't make your brain do a lot of work trying to keep your eyes in sync. So that's kind of the short of it. But we do evaluate for that at the Headache Center, which is one of the only places in the world that can be checked for and treated.
And how often do you see that, Carol?
Well, if my population's a little bit different. So if you're taking chronic daily headache patients, it's a fair number of those. I guess I haven't come up with a a percentage yet because we're still researching this, but it is available to patients. But a lot of the patients that come through my office, I would guess probably 30 or 40% maybe of the chronic daily headache patients have this. Yeah.
You know, both you and Dr. Holm mentioned iGrain, and I wasn't sure what you were talking about. Was it EYE, iGrain? Is that what you're calling it?
Yeah.
Okay, I've not heard of that before.
No, this is Carol's research, and the lenses are kind of spendy. How effective are they?
Well, we do a lot of sorting at the front end. So we screen them by asking questions and then doing this test called the Sight Sync. And so we only will offer it to patients who we're really almost 100% sure they're going to be effective for them. So we do a lot of screening and tell patients, you know, I think you have a pretty good chance, but it's you know, moderate. I'm not 100% convinced. But if we think they're a great candidate, we'll let them know that. And then we work with them. So we work with Care Credit, which can make it even, like, I think it's like $100 a month if you work with Care Credit. So we do that all at our office.
We have to end. Carol, I can't tell you how much I appreciate it. And don't forget to watch the show tomorrow night. You're on that show, and it's going to be, it's a fabulous show. Thank you so much.
We hope all of you have enjoyed our Prairie Doc radio program, and we'll listen again for Prairie Doc, brought to you by the Avera Medical Group Brookings. If you can't watch tomorrow night, you can actually catch the episode right now on our website, prairiedoc.org. Please join us next Wednesday on KBRK. We're going to discuss end-of-life care. Rick, that's all till next week.
Thank you, Joan, and thank you, people. Be healthy out there. Good night.
AM 1430 is KBRK Brookings. We now join CBS News.